My name is Deeku Mandavia. I'm a practicing emergency physician and the chief medical officer for Ceribell. One of the things that's important to recognize what's happened over the last 10 to 15 years is significant advances along a lot of different important clinical problems, such as stroke care, trauma care, myocardial infarction, STEMI, cardiac arrest care, and sepsis care. Non-invasive monitoring is completely the standard of care. We have non-invasive monitoring for vital signs, for cardiac rhythm, for oxygenation, for ventilation, and for hemodynamics. So brain monitoring is conspicuously absent in the care of these critically ill patients until now. So classically, how do you measure or how do you evaluate brain function? It's with a physical exam. Ask the patient to do certain commands or check the level of consciousness. It's a very tedious process. It can be unreliable. It's often inconsistent. It requires the patient really to be under constant observation, which is really not that practical either. And in certain cases, it's completely impossible because the patient's intubated on a ventilator and paralyzed. There's been no real objective or continuous assessment of this neurological function until now. Ceribell is a medical device company with a primary mission of improving neurological care for emergency and ICU patients. Ceribell developed the world's first non-invasive brain monitor incorporating both AI and cloud-based computing. They've created a new category that's been designed for point-of-care clinicians. They have miniaturized EEG technology, easy to apply and use, that provides rapid clinical answers at the bedside. Furthermore, the ordering physician does not need to know how to read an EEG because the AI algorithm will provide bedside risk stratification for you. So now this rapid EEG technology can be brought to frontline emergency and critical care doctors, and the first Ceribell application is the rapid detection of seizures. There are three categories of applications. Number one is altered mental status with a high-risk condition for non-convulsive status epilepticus. Number two is cardiac arrest with return of spontaneous circulation. And number three is patient with seizures and assessment of that clinical condition. So let me take you through the high-risk conditions. So a patient with altered mental status can have, besides an underlying condition, can have coexistent non-convulsive status epilepticus. These are patients that may just be unexplained altered mental status, or those with these conditions that I've listed here. So whether it's a known history of seizures, a patient with a stroke, whether it's ischemic or hemorrhagic, subarachnoid hemorrhage, traumatic brain injury, brain tumor, a recent neurosurgical procedure, those with CNS infections, those that suspected have sepsis-related encephalopathy, those with toxin or metabolic derangement, and anoxic brain injury. So all of these conditions can cause altered mental status, but we want to rule out the presence of coexistent non-convulsive status. The second large category is the patient with cardiac arrest with return of spontaneous circulation. So we know the vast majority of these patients have anoxic brain injury that puts them at really high risk for non-convulsive status epilepticus. In fact, about a third of these can have non-convulsive status epilepticus, and that's why the 2020 AHA guideline actually recommends rapid EEG on the patient with return of spontaneous circulation. It's also important to understand many of these patients are going to have therapeutic hypothermia protocols, and they may have shivering, and shivering may cause some tonic motions that may be confused with seizure activity. Furthermore, almost all of these patients are intubated, and some of these may be paralyzed, further masking even convulsive seizures. And lastly, the patient with seizures, and this is a broad category. So you have patients with obvious convulsive status epilepticus that is evident to the clinicians, those with seizures with prolonged postictal period, those that need active medication titration. Those are very important patients to monitor. Patients where you are wondering about seizure versus syncope, and those that you're worried about potential pseudo-seizure. Ceribell has significant advantages. You have improved diagnostic certainty and improved risk stratification, earlier diagnosis and treatment, decreased morbidity and mortality, quicker disposition to the right location, decreased length of stay with an overall reduced cost of care, and enhanced compliance with clinical guidelines. If you've not yet seen much about the device, I recommend you go to our homepage at www.ceribell.com.